let me introduce our speakers, who are probably no strangers to many of you. Katie Devlin is the Vice President of Interoperability at Cotiviti, where she is responsible for creating an enterprise digital data exchange strategy. Katie oversees initiatives related to digital data acquisition, ingestion, storage, and normalization, as well as the expansion of Cotiviti Electronic Health Data Network to optimize compliance, efficiency, and value for our clients. Adam Gilbert is the Director of Interoperability Operations and Partnerships at Cotiviti. Adam works collaboratively with payers, providers, and data partners to deliver and increase the use of digital data exchange. With over 20 years of experience in healthcare operations and consulting, Adam is responsible for driving effective interoperability programs and operational excellence. And now let me turn it over to Katie to kick things off.
Thanks, Michaela. I'm thrilled to be here. So let me just walk you through what we're going to cover today. We will kind of just give a brief introduction to level set on how we're talking about interoperability and what does it mean and how does it impact payers and providers. We'll walk through some of the key trends and opportunities that we're seeing when you're creating a strategy. We'll talk about how we can drive value, optimize return on investment, and reduce cost savings when you're building out this strategy. And then lastly, we'll talk about how you can optimize the performance within your organization. And we will certainly leave time for questions. Okay, so just to level set, I think interoperability can mean different things to different folks based on your particular organization and your needs, your use cases. But if we think about it at the highest level, it's really a term for effectively exchanging information. And obviously in healthcare, it's not just good enough to send the data somewhere. It's got to be the right data sent to the right person at the right time and in the right format and workflow. Otherwise, it just doesn't work the way we hope, right? And when we achieve interoperability, we can improve operational efficiency for things like prior authorization. We can also power digital quality programs, which are now built on the FHIR standard. We can improve data-driven decision-making, especially when it comes to things like identification of care gaps or member stratification. And with all of the CMS mandates and the relatively newer regulatory changes that we've seen over the past few years, I think that there is sort of this misnomer where the industry tends to think that FHIR is synonymous with interoperability, FHIR being fast healthcare interoperability resources. But really, we should be thinking about FHIR as one protocol or standard that is used to help achieve interoperability. And when we think about creating a strategy, right, it's really about developing this multi-pronged approach where you can leverage various standards and protocols across a number of different use cases, whether those use cases include acquiring clinical data or CMS compliance or digital quality measures. And the latter, we talk about CMS compliance. Those are actually new use cases that Cotiviti can now support with our EdFX merger. Health plan interoperability in particular is really broad. So for the purposes of this presentation, I'm going to focus just on the clinical data acquisition use case. So why does this all matter? We will talk as we go through here. Adam and I will cover how we can make data-driven decisions with the data that is exchanged across different parts of the organization and with different stakeholders. We'll walk through how interoperability can create efficiencies and then how it can also improve outcomes both for members on the payer side and then for patients on the provider side. Okay, so we do have a poll here. So if you could just answer how your interoperability strategy is progressing. We've got a few different options here, and we're just going to wait for the majority of folks to respond. All right, well, nobody's completed, so that's good. I guess we're all in the right place here. Okay, so yeah, it looks like almost a pretty good split between research and planning, but haven't started. And then a lot of folks are still at the start of their roadmap, and a few lucky folks are well in advance of their roadmap. So good to hear, and that will help us sort of zero in the conversation as we continue. Okay. So we're going to walk through some of the key trends that we're seeing and really what that tipping point was for when interoperability became something that is actually achievable. So now, one of the things to keep in mind is, again, we talk about FHIR all the time. And while most EHR vendors have FHIR capabilities that will make it easier for providers, payers, and other stakeholders to work together, and that really is across all of the use cases that we've talked about. Um, However, it's important to note that while these capabilities exist, the majority of data is still shared via CDA documents or clinical document architecture. And that's because during the HITECH Act and meaningful use, if we think back, that is really what these EHRs built their infrastructure on. And while the vendors have kind of caught up, right, and come along with FHIR and those more modern capabilities, the provider workflows remain mostly grounded in CDA when it comes to sharing data with payers. So when you're thinking about creating a strategy for acquiring clinical data electronically, this is a really important consideration. You really have to build that bridge for providers until we get to a place where FHIR is the most widely used protocol. And we will get there thanks to regulations like the Cures Act and the Interoperability Final Rule and frameworks like TEFCA. So how do we get started though? So first, there are really three things that we have to consider as we're building our strategy and keeping in mind that there is no silver bullet solution for this. So first is really provider participation. Provider participation in sharing clinical data electronically with payers is still optional. So if the provider or health system doesn't have the resources to build a connection with you right now, that might mean you have to get a little creative and get the data through another means. That could be a vendor partner, who the provider works with, or maybe look to a participating health information exchange, either at the regional or the state level, or a national network as well, where the provider contributes data. The second thing to keep in mind is really how organizations find their patients. All data partners have slightly different ways of finding the records that you're requesting. This is not something that is at the EHR vendor level, at the Epic or the Cerner level. There are still unique configurations that can be done at individual sites. So some of these organizations might take a deterministic approach where they say, if I don't have an exact match for Kathleen Devlin and all of her demographic information, I'm not returning a record at all. And a lot of times there's a tendency to do this because it's safe. It mitigates issues regarding sharing PHI that might belong to another patient. So very understandable. Other organizations might take a more probabilistic approach for matching, where if there's enough demographic elements or what we call chase data elements on the payer side that can connect Kathleen Devlin to Katie Devlin, then they'll return a result that they're pretty confident in. And of course, when we're building out this strategy, that is the preferred approach because it yields more data. But it's something to keep in mind because you don't necessarily have control over that. And Adam will talk through some of the metrics that you should track and how we can work with our data partners to improve those matching algorithms if you're having issues. But then lastly, it's not just enough to look at the match rates and sort of reasons why a record wasn't returned at the transaction level. That's obviously important, but perhaps the most obvious thing here is to ensure that the content of the data is really what you need and your stakeholders need to fit your specific use cases. So for example, risk adjustment coders might be hyper focused on efficiency. So they are very specific about wanting, encounter level data. They might not care so much about all of the additional longitudinal information that is in a continuity of care document. Whereas, maybe on the quality side, the more data, the better, right? Again, to identify care gaps, et cetera. And, you can get kind of creative in how you create different views of that data based on your stakeholder needs. So that's something to think about as you're creating these relationships. And regardless of the type of data partner that you work with, though, you do have to consider the exchange purposes or really the use cases that they support. And as you can see, we've got sort of this inverted triangle here. Treatment and individual access use cases have high adoption because it's really mandatory across the industry. These are instances where data is shared in order to provide care to the patient or to ensure patients are able to access a complete copy of their records, broadly speaking. But really for payer data exchange, right, we're on that middle layer here where we're focused on payment and healthcare operations use cases. And those are generally supported across the industry, but not mandated. And I think that's a really important distinction for us to make. And it's probably best illustrated when we talk about health information exchanges. So the vast majority of them share data across national networks, for treatment and individual access purposes. And while the national network itself might support requests for data that fall under payment and operations, the participating HIEs that are contributing data, they're not mandated to respond to requests for payment operations. So there is a nuance, as you're creating these relationships that you have to keep in mind and make sure that these use cases are supported by your data partners that you're working with, whether that partner is a direct provider healthcare system, a health information exchange, or a data aggregator type of partner. So, oh, go back. So keeping those use cases in mind, yep. Here are some common types of integrations that we can help accelerate your strategy and really create value. Again, remembering that there is no silver bullet here. So you really should kind of think about doing what we call, Ecotivity, this bottoms up approach, where you're working directly with the health systems and provider offices. You're getting data use agreements in place, but then also taking a more top-down strategic approach to partnerships where you have a one-to-many connections instead of just a point-to-point connections, right? When you do this, you of course need the ability to leverage various types of interoperability protocols, whether that is, the FHIR standard or traditional IHE-based protocols, or even a web-based, portal where organizations can share their data with you. And as you create these integrations, there are really some things that you should keep in mind. So first, provider adoption. Kind of building upon the HIE scenario we just talked about, when we think about tools like Epic Payer Platform or really any EHR vendor platform, providers are not required to participate and share their data via that mechanism. So we have to keep that in mind, that it is not a one-stop shop. Epic Payer Platform or any EHR vendor solution is not going to solve all the problems. There is still a lot of data that is left on the table if you're only using one of those platforms. So you have to sort of bring together multiple types of partners like that. Second here is vendor lack of transparency. As you're trying to create these partnerships and figuring out who's going to be a good fit for you strategically, please be aware of data partners who don't want to share their list of organizations contributing data for your use cases. I've had my fair share of potential data partners who have said, yes, we have access to, 100 million unique patients across the nation, and that's great. But then when we zero in on it, it's for treatment and individual access purposes. It's not for payment and operations. And, if you get into a relationship like that without really understanding the use cases and what organizations are sharing data under those use cases or exchange purposes, it's not going to be cost effective, and you're not going to get the value that you hoped out of that relationship. Varied data presentation. As we aggregate data from various disparate sources, the format of the data can vary, right? Going back to FHIR versus the longitudinal CCD, you need to be able to accommodate all of these sources and bring them together to create a holistic view of the member, making sure that you consider both the foundational aspects like mapping to a common data model, for example, FHIR, but also the semantic aspects of this, right? Which, really include ensuring that you have the correct clinical ontologies and code systems associated with the data elements. So, one example is if we look at RX norm codes and you have one provider, for Katie Devlin, maybe it's my primary care, is sending Tylenol as a medication, but maybe I had an acute care stay, and on that medication list, it's coming through as acetaminophen. Being able to reconcile those medications, have the same description, have the same RX norm codes, same RX qui codes, making sure that everything is synonymous, so we're comparing apples to apples, is very, very important as you go through this strategy. Because otherwise, when we talk about, data-driven decision making and powering analytics, it's all going to fall apart. You have to make sure that you have that semantic layer in place. Sort of touched on data use agreements early, but making sure that as you put these data use agreements in place between your organization and a data partners, outlining all of the use cases for your organization, whether that's risk, quality, payment integrity. That way you don't have to go back and do updates to these agreements and further, kind of go back on your strategy, right? And you're not delaying anything in that process. when we talk about data and member mismatching, data and member matching, we talked about the types of member matching that can happen, but some other considerations are really NPI and TIN mismatch. A lot of these data partners require both of them to have an accurate match. And if you're only giving one, whether it's the NPI or the TIN, you run the risk of not optimizing the amount of data that can come back to you. So making sure that you have the most accurate NPI and TINs. Poor chase data, it's sort of, that age-old saying, garbage in, garbage out, making sure that you have a complete chase list, all of the complete demographic information that you need to make a good match to send over to your data partners. And then some of the things that we find too are no encounters within the date range. And this kind of goes back to the NPI and TIN mismatch where providers have, obviously their NPI number, but they can have privileges at multiple different organizations. So multiple different TINs could be associated to that NPI. So that becomes really important because if you have that mismatch, you could match on the patient, but then have something come back that's called a no encounters found or no information found, where basically no documents are returned on that member or patient because that provider maybe had privileges at a different organization. And that's the one that was contributing data, not the one you were actually hoping to get the information from. So just ensuring that you're querying the right partner for the right use case with the right information is very, very important to optimize, again, the amount of data that you're getting back to drive your strategy. And with that said, I'm going to hand it over to Adam to go through how we can optimize performance.
Thank you, Katie. And thank you everyone for joining today. Katie discussed key trends in interoperability, challenges and opportunities, and also how to drive strategic value. I'm going to discuss how do you execute or optimize performance in your interoperability initiatives. And from the poll a little earlier, there's about 75% of the attendees that was either very early, they're in the very early stages of their strategy. So I'll hope to give you some key considerations as you launch that as well. But as patients, we've all felt the pain of trying to transfer medical records between the HIPAA release forms, wait times, misplaced records. The process of trying to give a new provider our health data is filled with friction and blind spots. This friction exists between organizations inside the healthcare system as well. Insurance plans struggle to obtain clinical data from providers, and providers struggle to access the plan's member claims data. And then healthcare vendors struggle to access data from both sides, even when the appropriate agreements are in place that Katie mentioned earlier. So today I'll review our key considerations that we have experienced in working closely with payers, providers, and data partners across the industry. And this is just scratching the surface. And I'm sure many of you have other ideas for your business. But really, the most important step to interoperability is data governance. And there's been countless security breaches in healthcare, from providers to health plans and very large healthcare IT vendors. We must ensure that we have a healthy data governance. And the first step of data governance should be to create a cross-functional task force with various stakeholders. And it's important not to leave anyone out of this process, and it's best to over-communicate from IT to legal, clinical leaders, and others, just to determine interoperability requirements and the impact on your current operations. You also need a team of individuals that analyze regulatory trends and track the impact on specific use cases, whether that's the 21st Century Cures Act, CMS Interoperability and Patient Access Rule, TEFCA. I mean, there's many others as well, but there's lots of changes, and you really need a team that's sole purpose is to monitor this changing landscape. Next, participate in external work groups and industry initiatives. As an example, the HL7 Da Vinci project. And if you're not familiar with this initiative, its primary focus is on accelerating FHIR adoption. You should also adopt standardized data formats, and this is critical. Healthcare is under tremendous pressure in America right now, and it's probably for good reason. U.S. spending reached $5 trillion, I read recently, and was almost 18% of our GDP. However, when you look at some of the patient outcomes, we can be doing much better, and we need to make improvements. Unfortunately, our industry hasn't benefited as much compared to some others that's growing more intelligent and more efficient. So the structured and standardized data will allow entities the ability to utilize machine learning and analytics to drive further insights and efficiencies. And we really view this as a game changer here at Cotiviti long term for our industry, because once these standardized data formats are adopted. Next, Katie did touch on this earlier as well, is establish data use agreements. I'd suggest not to limit your agreements, like Katie said, to one use case and have the goal of covering all different types to avoid multiple unique agreements. And then lastly, for data governance, select external partners to reduce the cost of innovation. In healthcare, there is an abundance of technology partners. You need to decide, do you want to invest in trying to build your own capabilities, or do you utilize proven entities that have tremendous expertise and experience in implementing interoperability initiatives? The next consideration is ensuring that you build a scalable infrastructure with diverse networks that can handle high volume data exchanges as well as interoperability standards. It's really important to integrate with various formats, connections, and networks. As Katie mentioned, there's no silver bullet, so you don't want to rely on a single solution or type of connection. There's HIEs, data partners, EMRs, data aggregators. So again, there's no single method that yields the greatest results. So you really must engage with multiple different types of entities. And records are usually retrieved in various formats like FHIR, CCDs, PDFs, but there's also various sources of that same data. So it could be EHRs, lab results, and claims data, just to name a few. So you want to ensure that you're able to integrate with various formats. That's really critical. Next is launch or integrate FHIR-based APIs. A good data partner will be able to connect to various EMRs like Cerner, Epic, and others, just to name a few, via FHIR-based APIs. Overall, you really need a multi-tiered approach to respond to specific markets and business opportunities while achieving regulatory compliance. So if you can accumulate enough structured data or records, the possibilities really become endless. If you have better data, you have much improved insights. Consideration is really critical as well to the success of your interoperability program, and that's data partner collaboration. You will likely be partnering with many different types of organizations, and it's important to ensure the secure sharing of the data via encryption standards and regulations. And the next point is extremely challenging at times, and that is enhanced patient matching accuracy. In an ideal environment, every patient you need records for would be returned quickly and accurately by providers and other data partners. However, medical records retrieval is arguably the most difficult aspect of risk adjustment and quality programs. You must overcome, some of the things that Katie stated earlier, data inconsistencies. There's low response rates, and you're all the while trying to avoid provider abrasion. And then in addition, some data partners will utilize the NPI for matching to a provider. Others use the 10 regardless of the NPI. And then some use 10 plus NPI. And we've worked with others that use a combination of the provider name and address, and then sometimes a 10 and sometimes only the NPI. So it comes down to, how do you match to your providers? How do you match to the members? Should you include member address data to increase matching? Or if a demographic for that member is included, like city, state, zip, or others, and it's incorrect, how much does that lower your potential for a match? So these are all very important considerations to work collaboratively with your data partners to increase matching. So enhanced patient matching is critical. Next is robust data mapping to various standards and EMR systems and versions. It's important to identify how many EMRs is the data partner able to connect to. What standards do they support? CCD, FHIR, is it just PDFs, or is it no standard? Currently, healthcare organizations, many of them at least, are using different standards, or even different versions of the same standard. And this means that it is essential to have a robust data mapping and quality management strategy. And then lastly here, conduct monthly data quality audits with data partners. This is essential to ensuring data accuracy. We utilize data or a data quality scorecard by data partner to regularly confirm that all the data elements are returned back to us. And you don't want to go through the effort of retrieving data, especially due to all the challenges of the patient matching that I just discussed, if it's not complete. So that the conducting the monthly data quality audits cannot be overemphasized. The next consideration, implement key performance indicators. Again, here's just 5 of the KPIs that we recommend. However, there's many others, but we find that these are the most important for the businesses that we interact with. So first, data quality. I just briefly discussed this one. Probably the most important metric, as data isn't valuable unless it's, as Katie said, the right data at the right time, in the right format, and in a very cost-effective way. So you may want to focus on what's the percentage of records that contain all of the required data elements for my use case. Next is system availability and uptime. How often is your platform and the system of your data partners reliable? Is there regular downtime or system maintenance that impacts your ability to connect and retrieve data from them? Response message processing time. How long does it take from the moment you submit a request to receive or retrieve a record? You could also look at this one a little differently. It could be from the moment you receive a request for data, how long does it take to submit a request to the partner and then retrieve the record? So those are 2 very different metrics, and both are extremely valuable. Next one, record retrieval success rate. What's the percentage of requests you submit to data partners that are returned with a record? Do you have a high number of patient mismatches or no encounters in that date range that was requested? Are there other processing errors? Are there providers that opted out and that have not agreed to share their data? These are all important reasons that could very negatively impact your record retrieval success rate. And then lastly, the cost savings or ROI. You could look at the cost per record retrieved after removing any fees associated to data partners retrieving records on your behalf. Another interesting way to measure the ROI specifically is the reduction of manual processing time by streamlining your interoperability workflows. So again, that's just 5. There's many others, but that's a good starting point. And then lastly, now that you have the KPIs to measure interoperability success, it's important to share that data with stakeholders to align efforts via leveraging dashboards and analytics. First, implement dashboards to monitor KPIs. You can use a platform like Tableau or Power BI to provide real-time visibility into your KPIs, enable you to monitor, analyze, and improve your processes. You can also use intuitive visuals like a bar graph, a line chart, heat maps, possibly of your connections, and then also evolve even further by adding interactive features, allowing data to be filtered by time period, data partner, or even drill into specific metrics, like the KPIs I mentioned a little bit earlier. It's important to analyze the vendor matching results. You can compare your vendors with various metrics. Example would be percent matching to a member, percent no member match. So some of those same KPIs, and then of course the percent no encounters in a specific date range. So these will help identify any potential gaps that you may have amongst your vendors. Next, identify benchmarks. You want to try to compare your metrics against industry standards. The ONC interoperability reports have some good data, but you can also try to compare against your peer organizations, and so that could be difficult to do. Next, examine trends in data and initiate improvements. There's many different ways to handle this one. You may want to implement root cause analysis in data to identify KPIs, and then implement a feedback loop with your key stakeholders as an example. But it's important to always drive for continual improvement in your interoperability programs. And then an example dashboard that you could utilize or deploy Tableau to monitor one of your data partners on their patient matching. Then how quickly are records and responses returned. If your patient matching is less than 85%, maybe an alert's created that prompts analysis into the cause. So it's important, again, to always make improvements in your interoperability programs. I'll go ahead and hand it back over to Katie to share information regarding a case study that we recently completed. However, I'm happy to share any additional information. And as I mentioned earlier, this is really just the tip of the iceberg. And we'd love to continue more conversation after the webinar as well. So Katie, I'll go ahead and hand it back over to you.
Thanks, Adam. Yeah, so Adam talked a lot about data quality and making sure that the content of the data that you're getting is what you're expecting, right? So in that vein, Cotiviti recently completed a study where we looked at hundreds of continuity of care documents across a range of different digital partners that we have. And in a nutshell, one of the national networks that we work with was the top performer with 94% of all of their records having all of the data elements completed. And when I talk about the elements that we looked at, it was sort of all of those key core elements for both coding, and abstractors, what they look like, what they look at. So encounters, medication lists, past family history, review of systems, clinical notes, and a few other data elements, both administrative and clinical. So it really wasn't surprising because this particular national network is also a QHIN, a Qualified Health Information Network under TEFCA, and has undergone rigorous testing and onboarding from a content standpoint. But really, with most of those fields being near, 100% accuracy, it just suggests a very high, and robust data extraction and normalization process within their system, going back to that semantic normalization piece, right, where we're making sure that we're comparing apples to apples and having, sort of taking it a step further as we're bringing data in from just different providers. What we really saw, though, was high variability between EHR vendor solutions. We had one that was pretty lacking, with only about 45% of their records having things like past medical history, review of systems, and results, which is a pretty big one. Whereas we had another EHR vendor solution that showed what I would call more moderate completeness in sort of core fields like medications, problems, and encounters. And they were all between 85 and 100%. But we did see that particular partner struggle with lab results and review of systems. So, it just shows that there's just a lot of variability across these different data partners. So that's, just speaks volumes to why you have to have those sort of data scorecards and do those audits and monitor the completeness of the information. And just some of the other things that we looked at too, where we saw very strong clinical documentation, was on the chief complaint, history of present illness, that was at 100% across everything. And then diagnostic test results overall were very high. So, again, just this, I sort of just spoke to some of these, but again, shows you the importance of data completeness. We plan to take this study a step further and then look at, well, what were the results, right? What were we able to abstract? What were we able to code off of those particular records that were retrieved? And what was the actual value to the health plans that we work with? So I look forward to hopefully sharing some of those high-level results in the next 6 months or so. But again, it also highlights, right, these, the variability and the, channel-related and industry-wide challenges that we're seeing, right? Again, with, lab results, review of systems, going back to that garbage in, garbage out. Sometimes, when you're working with an aggregator type of a data partner where it's that one-to-many connections, it's a strategic partnership, it is nearly impossible to test every single contributor of data. So you might have, 80% of those partners in an HIE that are contributing all of the data, and it's very strong and very complete, but you might have one or two health systems within that health information exchange that aren't really very good at documenting certain things, or they're not sharing certain sections of the CCA, or not sharing certain FHIR resources appropriately. And it doesn't mean it's a bad data partner, but it's an opportunity to capture that information, go back to the HIE or the data, the aggregator data partner, and have that conversation so they can then talk to that provider themselves. So really, it's just very important to monitor and constantly, try and improve and work with your partners, as Adam said, have that collaboration. And then, something else that we saw too was that our direct point-to-point connections, going back to sort of that grassroots, boots on the ground, bottoms up, whatever we want to call it, all of those point-to-point connections that Cotiviti has in place, be that FHIR or an IHE type of connection, they were the second most completed type of data partner that we looked at. So very, very high data quality. And I think that is related to the amount of integrated testing that we can do. It's one partner. We can be a lot more specific with all of the data elements that we're looking at, and really be very, very thoughtful about how we're bringing them live. Whereas when you're implementing with a more of an aggregator level partner, you have, you could have hundreds of thousands even connections, and it's impossible to test every single one that's sharing data into that partner. So just some things to think about as you develop these partnerships. So with that, I think we have some time for Q&A.
Yes, thank you, Katie and Alan. We are now going to answer questions from the audience. And as a reminder, you can still submit your question by clicking on the Q&A box. One question that we have for you is, can you tell us more about your experience in provider and user engagement?
Sure. Adam, you want to take it?
Yeah, it's a great question. So here at Cotiviti, we have a team that's dedicated to what we refer to as provider outreach and engagement. And what they do, they call strategic providers for not only Cotiviti, but our partners and customers to discuss FHIR and other methods of retrieving records. Providers, even very large organizations, vary significantly in their adoption and awareness of TEFCA and the various interoperability standards, really. So we really try hard to meet the providers where they are. And what I mean by that is, some simply just need an SFTP to load records, while others are very far along their interoperability roadmap, and they already have their FHIR APIs, as an example, published and public, and you can see their endpoints, and we're able to obtain and retrieve records via those same endpoints. We've also had great success with three-way conversations with the provider and the payer. So we've had good success with that as well. So that's a great question. Thank you.
Thank you, Adam. Another question we have is, how does this help the move to digital quality reporting?
Yeah, I can take that one. So recently NCQA has mandated that payers move towards completely digital quality reporting by 2030. And Cotiviti's been very much on top of this because we, of course, have to be ready to support our clients well before, in advance of that timeframe. So, FHIR, again, Fast Healthcare Interoperability Resources, is the standard that these digital quality measures have been built on. There are HEDIS-specific implementation guides. So as you're bringing in all of this data, making sure that it is mapped appropriately, enriched, from a semantic perspective, you have all the correct coding systems, et cetera, that will sort of power your ability to effectively report these measures digitally, right? So making sure that you have the capability to ingest the data, even if it comes in a CCDA format, that's okay. But being able to ingest that data, map it to FHIR version 4 in particular, and then furthermore have that terminology and normalization service on top of it. So now you're sort of level set, apples to apples comparison across all of your sort of data sources, and then furthermore map it to the HEDIS implementation guides. That's going to optimize your chance for success. And then you can, take it a step further with quality and identify care gaps and have more of a bidirectional kind of interface between the payers and providers.